Sickle cell syndromes. Etiology. In the sickle cell conditions, there is a qualitative defect in the SS globin chain due to a single base pair substitution resulting in valine replacing glutamic acid at position 6. Hemoglobin, HbC, is formed after substitution of lysine for glutamic acid at the same position. The tendency to sickle is reduced by the presence in quantity of non-S hemoglobins, and high HbF levels are protective from acute complications. The heterozygote state confers protection against falciparum malaria, and the gene has been conserved in malaria-affected areas of sub-Saharan Africa. Geographically, HbC occurs in West Africa. In the UK, an estimated 15,000 individuals are affected by the sickling disorders. Figure 14 illustrates the inheritance of the sickle cell syndromes. Clinical presentation. Genotype HBSS, sickle cell disease. Red cells are wider than the capillaries they have to pass through, and therefore the cells must fold to enable them to circulate. At low oxygen tensions, the HBS crystallizes and distorts the red cell shape, a phenomenon called sickling. The sickle cells are unable to fold and consequently block the capillaries. This prevents the further passage of red cells, lowering oxygen tension and resulting in local ischemia. The diagnosis is confirmed by a SickleDex test for Hb solubility and Hb electrophoresis, Fig 15. Laboratories with a high throughput can utilize high-pressure liquid chromatography to separate the different hemoglobins. The clinical course is one of chronic hemolytic anemia punctuated by crises. Bone pain crises caused by marrow infarction are the most common hospital presentation. Crises may also occur within organs such as the spleen, lungs, liver, and brain. Stroke, a devastating complication, is found in 8% of children. Repeated splenic infarction leads to functional hyposplenism by early childhood. Subsequently, patients are at increased risk of infection, particularly by encapsulated organisms such as Streptococcus pneumoniae. Aplastic crises may occur following infection with parvovirus B19, which usually requires transfusion support. The management of a sickle crisis, as well as the laboratory findings in sickle cell disease, is covered in section 1.4.1. Hydroxycarbamide, hydroxyurea, which increases HbF, can reduce the incidence of painful crises, acute chest syndrome, and the number of people and units transfused by 50%. However, even if those with sickle cell disease survive these potential problems, their life expectancy is reduced to about 50 years. Allogeneic bone marrow transplants offers a potential long-term cure. All surgical procedures and pregnancies should be managed with the assistance of a hematologist. Genotype HbAs, sickle cell trait. Patients with sickle cell trait are not anemic and rarely suffer crises. However, in rare instances, crises can be precipitated by severe hypoxia, being in an unpressurized aircraft, or septicemia. Once again, hematological advice should be taken for surgical procedures and pregnancies. Genotype HbSC, hemoglobin SC disease. Patients with SC disease have a mild anemia and suffer fewer crises than people with SS disease. Women are at increased risk of venous thromboembolic disease during pregnancy. Retinal ischemia leads to proliferative retinopathy and may proceed to detachment. Yearly ophthalmological review is recommended in all adults with SC disease. As with the other sickle syndromes, pregnancy and surgery should be discussed with a hematologist. Genotype HbAc or HbCC. Both the heterozygous and homozygous forms cause minimal problems. Homozygotes, HbCC, may have a mild microcytic anemia and occasionally splenomegaly. The blood film shows many target cells, Fig 16. NB. Combinations of genetic defects in globin synthesis may occur in the same patient and present a wide variety of clinical problems. The further discussion of such syndromes is beyond the scope of this book.